So the American Academy of Neurology guideline is an update in some ways of a previous guideline. Why was an update necessary? Well, the landscape for MS care has changed dramatically over the last several years. So we now have 17 FDA-approved therapies for consideration, which is a marked shift. And that shift includes not just more agents, but drugs with different routes of administration, different levels of efficacy, different side effect profiles, so a lot more considerations for the clinician. So this guideline tries to synthesize that evidence so that clinicians and patients, when they're talking about therapies and appropriate choices at the individual level, have that information summarized and put together in terms of guidance, as you mentioned, in both recommendations around stopping, recognizing when it might be appropriate to switch therapies and when one should consider stopping therapies. And so that is all meant to come together to try and address common clinical scenarios that people with MS and the clinicians who are helping to care for them will face in clinical practice. Well, I think the guidelines recognize that there are a lot of individual factors, and so the first thing the guideline tells people to do is have a conversation with individuals with MS about what the therapies are intended to do, so that they have a reasonable set of expectations around those therapies. They can balance the expected benefits of those therapies around the potential risks. First thing is making sure both people are on the same page about the information available, and that's the first thing to any informed decision. The guidelines also talk about thinking about what the individual's preferences are. So is the individual ready for a therapy at all? So if you're not ready to take it, it's not going to be helpful to you because there's a big commitment to taking therapies. And then if you are thinking about taking a therapy, what are your choices and what are the considerations and where do your preferences fit in? So are you somebody who would tolerate a higher or lower level of risk around a therapy? Would you prefer an injection or an oral therapy? Does it matter to you how often it's taken? Does it matter to you how often you have to go in for monitoring of that therapy to ensure that it's taken therapy so carefully and safely? So these guidelines make sure that clinicians and patients are aware of all of these factors, which are really important to making a choice of therapy that will be good for the individual with MS and that it is safely monitored. And it also provides guidance about what if the therapy doesn't seem to be working, what do you do next? So it starts at the beginning. When you have a first attack and you're at risk for MS on the basis of your MRI, start treatment early, and then it says, if you don't do well with that or you don't tolerate it, what do you think about? Many patients with MS are women, and so it also recognizes that pregnancy then becomes an important issue. So what do you need to think about that's special under those circumstances? So the guideline really walks you through a lot of those scenarios and the considerations so that each patient-clinician dyad can make the best decision for that individual. So the guideline recommends that discussions about treatment be made at a second visit, remote from diagnosis. And the reason for that is there's a lot of literature around individuals receiving a serious diagnosis and about the emotional impact on the individual and the inability to really absorb other important information after you've told somebody about a potentially life-altering diagnosis. And so there's not much point in telling people things that they can't think about and weigh, because going on treatment is a real decision that takes careful thought. So by doing that at a second visit, when the individual's had some time to adapt to that, you can really engage better in that shared decision-making process. Sure. Well, I think as compared to the European Academy of Neurology guideline, the American Academy guideline has heavily emphasized a lot of the counseling guidelines around expectations and making sure people really understand risks and benefits in therapy and those kinds of considerations. So I think has laid that out more explicitly, which I think is helpful for clinicians in terms of thinking about things. There are some slight differences in terms of the weight of some recommendations. And in particular, there isn't a recommendation about what to do around patients who may not be able to afford therapy. And so there isn't a recommendation to do off-label use of medication to account for that or to point people to specific organizations that might be able to help with those costs. And that likely reflects some differences in the environment in the two countries. And then I think the two guidelines differ to some degree in the sort of specificity around pregnancy recommendations. The American guideline is somewhat more conservative in terms of recommending stopping all therapies and not initiating any during pregnancy, and the European guideline is slightly less conservative in that respect. But I think the two guidelines do agree broadly in terms of the importance of disease-modifying therapy use and the importance of using it early, and the importance in considering patient preferences in making those decisions.